Shall we start? It's already 3 o'clock.
Yeah, sure. Okay.
Good afternoon, everyone. Thank you for joining for our final week of Respiratory Medicine Month. I'm Dr. Ang from Hospital Taiping. We are very glad to be able to have Dr. Irfan, our consultant respiratory physician from Hospital Pulau Pinang, to present to us on topic of COVID-19 pandemic, TB control, and latent TB treatment. The chairperson of today's session would be Dr. Razak, lecturer from Masa University. So, Dr. Razak, the floor is yours.
Yeah, thank you, Dr. Ang, for inviting me and also for the nice words. I'd like to welcome all participants for this afternoon's webinar by the College of Physicians. And today we are very fortunate to have Dr. Irfan from Penang. Very interesting, going to talk about three main things. One is COVID, and the other one is TB, and the third thing is on latent TB infection. And I think to speak on all these three topics, he is the best person because he is a chest physician #1, and he is also the national head for respiratory services in Malaysia, and he is also the head of the department in Penang, respiratory department. And I think he's very experienced to do all these three things because he's handling them personally, all these diseases. And I think you all know Penang is now one of the main area for COVID infections. And again, the complication of COVID and the lung disease. And Dr. Irfan is also involved with the TB control program for the country as a head of services. He can talk very well about TB control program and also LTBI. So with that, I'd like to invite Dr. Irfan to give his talk this afternoon. Irfan, please.
Thank you, Dato', for the very kind words. Is my slides up, Dato'?
Yeah, I can see your slides.
Okay.
Maybe you can show them in the slide view.
Yeah, why is slide view went off? I thought it was a slide view. Hold on, Dato'. Let me try again.
The slide show just now on top there, there's an icon.
Is it okay?
The slides are okay, now very good. You can see the slides.
Okay, thank you, Dato', for the kind words. Actually, I think Dato' is probably the better person to give the talk. And I think, Dato', I joined your LTBI treatment talk last week for the MMA conference. I think it's just a follow-up to that.
Yeah, thank you very much.
So I think the topic now is COVID-19 pandemic and what it did to our TB control program. So these slides are basically made for year 2020, when our pandemic was not too bad at that time. So now I think things have probably changed. So we are not sure what's going to happen in 2021. So I'll try to finish off everything within 30 to 45 minutes. And then maybe we can do a bit of Q&A. So let me just minimize this. Right. So I think WHO came up with a statement. This is all based in 2020. So some things may have changed because the pandemic changes very fast. So what they do say is that definitely those who got TB will get worsen, will get a more severe form of COVID. So COVID will worsen TB, TB will worsen COVID. So they've come up with a standard precautions. That means wear your mask, so on and so forth for the TB patients. So I think if you read the press statements that our country DG gives every day, you'll see that when the people who pass away mortality, once in a way you'll see tuberculosis there as one of the comorbids. So it is a correlation. So way back when it first started in March 6th, this is all old papers from March of last year. People actually have already done studies in China when it first came out in China. So what this paper did was actually quite interesting. They actually determined latent TB, active plus latent. That means they actually did igra for all the patients who had COVID. And what did they find was, I'm sorry, it all comes out a bit slow, a bit small. But what they found was actually 36% of them actually had LTBI, those who got COVID. So this more or less corresponds to we expect 1/3 of our population to have latent TB anyway. But they go on to say that actually the MTB infection is most common compared to other comorbids. So this is what we don't test in our patients. I think our COVID cases are so high, we don't have time to do an LTBI testing for them. But this is what they found out way back 1 year ago. So their conclusion, I think it's a bit overboard. They said MDT infection increases susceptibility to SARS-CoV, but they do admit that probably larger validation studies need to be done. But there is already a correlation seen 1 year back. Then came up with this paper. So basically the risk of death in COVID patients with TB is 2.17 times higher. So there is 2 times higher chance of dying if you have active TB and you get COVID. So I think we need to be careful with all our patients, our TB patients. We need to tell them to be, take very strong precautions. And now with the vaccine available, ask them to re-register and get the vaccination done now. Right. So what has changed? I think many of us, depending on where you work, I think on the load that you're getting, the way chest physicians at work has probably changed quite a lot. We're doing less bronchoscopes nowadays because it's an AGP. So what we do nowadays, we tend to diagnose more smear negative TB. That means what if it looks like TB but they cannot get sputum, we try them on 1 month of anti-TB first. Because of the way the direct smear is done, so those patients who have got COVID, if ICU refer to us, they don't normally recommend direct smear. The lab says direct smear can actually spread the germs because you mix the sputum. But gene expert is safer. So nowadays we tend to do a lot of gene expert. We no longer have daily dots. I think the circular came up last year. I think that circular is still in place. So you can allow 2 weekly packing to prevent congestion in your dots clinic. We are trying to get this virtual dots. So some KK has actually done virtual dots, but this was all again before the load came to 7,000, 6,000 cases a day. So virtual dots is probably the way to go in the future. That means you give all your staff a phone, and then they just call, and then with a WhatsApp, they take the medication in front of the staff through the phone. And sometimes when the patients are relatively stable, we actually try to omit the fourth month visit. If they're doing quite well, to reduce basically you want to reduce the congestion in the clinic. So you can, many places have gone around doing things differently according to the local situation. But things have changed definitely. So when all these changes happen, I asked Dr. Tan, my specialist, to do a small audit. So we compared historical comparison between these periods, April, July 2019, April, July 2020, and probably I think it'll be more interesting when we compare April, July 2021. Actually, when we had about 36 deaths at that in that period, there was not much difference in all the parameters we assessed. So whether we didn't see, we were expecting to see more mortality and more defaulters during that period, but actually it wasn't there. So early in the pandemic, probably our TB control program didn't reflect an increased mortality in HPP. What you can see very clear is, like, for example, gene expert. More patients die of gene expert simply because we used more gene expert in 2020. It doesn't mean that anything else, just because of the load of our diagnostic methods changed a bit early in the pandemic. So the rest of the things that we looked at, actually there was not much changes when we did this historical comparison. That comes all these papers again from China. So this was the first paper that actually got my attention. If it doesn't come clear what I think, Dr. Ang or Dato' just interrupt me, because sometimes I'm always paranoid when I talk to the screen.
It's clear.
Yeah. So when this paper came out again, the Chinese probably did the earliest paper. So this is going to be very small, but the main gist of it was many of their staff, as what is happening now in Malaysia and most places of the world, were diverted from the TB control program to the COVID control program. I mean, to the COVID, they were put in the COVID tents vaccination program. So the TB control went down, and their final conclusion is they actually used this word: emergency response is required in the near future. Once the COVID goes off, which probably hopefully will go, they say every chronic disease has suffered, not only TB. I mean, the diabetic control, hypertension control, people are not keeping to their cardiac appointments, so on and so forth. So we're probably going to see a lot of MI, so on and so forth, uncontrolled diabetic. But TB is the one that we're a bit more worried because it's an infectious disease. So and if you go into the literature, there's a lot of these letters written. A lot of people write letters to the editor from each country. I think Malaysia should write one. What are the effects? And the effects are all the same now. Whether you're in a small place like Sierra Leone or whatever, India, it's all the same. All their TB control program has been impacted to different degrees of severity on various countries all over the world. even the laboratory services. So this was in Europe early in the year, early in the pandemic, and they actually said the word they used was more severe disruption. So all the TB national regional labs services were all stopped. Okay, as the labs then had to concentrate on running a test for COVID. So for that period of time, a lot of TB was not diagnosed, even in Europe when they had a very bad outbreak middle of last year. So they came up with this term. This is the correct term. A syndemic means one pandemic worsens the other. So they worsen each other. So tuberculosis worsens COVID, COVID worsens TB. And this is the patients in India. And bear in mind, this was all the papers from India prior to their current problem they're having now. This was in 2020. 2020, India actually was faring quite well in the terms of COVID. But even if you look at the time when most of us went into our MCO in March, you will see the red line dropping. That is your dots. So dots started to drop, and you can see it very nicely in the graph. Even BCG vaccination begin to drop. So again, the TB controls begins to have some detriment after when you're faced with a heavy burden of COVID. Again, this is 2020. I'm not sure how is it happening now. But not so bad. So some people actually write some positive thinking. I like this paper. This letter actually said that because they present the same way, so COVID just probably unmasks some of the subtle active TB. They come because they're worried about COVID, because they cough, fever, runny nose, and then we pick up TB. So in our SARI ward, our so-called SARI ward, when it was activated in March, December, again 2020, we didn't have much COVID at that time, but we picked up 164 cases of TB. So maybe there's some truth to this. So maybe all those who are in the SARI ward, maybe if it looks like TB, maybe you screen for TB. So there may be some light there. Right, and that all got a bit more as we move into year 2021, after 1 year of the pandemic. So these are what have come up. So this is the recent TB Day, March 2021. Stop TB Partnership came up with this new data on the impact of COVID in the global fight against TB. So I think that the main purpose when I give this talk just is to I think now we are all concentrating our efforts on COVID, which is fair and good. I think that we need to do that because death rates are going up. But once it's over, I think we need to put our concentration back on all these other chronic diseases. So when they first projected the 3-month lockdown, that was what happened early last year in the first wave. The lockdown was only about 3 months. They predicted that it will set back your TB control program 5 to 8 years. So this was presented in the KKM TB meeting last year. They said 5 to 8 years, not too bad. Okay, so basically what it means that whatever we achieved in life, 5 to 8 years probably has been sort of wiped out. It means your death rates will start to go up to the year 2013, 2016. This is 3 months. So in 18 March 2021, now they said that after 1 year, the drop has now come to, the diagnosis has dropped 16 to 41%. The higher range of the diagnosis drop is in countries where the TB burden is very high. So now we're talking globally, we're not talking about Malaysia. So the overall setback is way back to 2008. 12 years, our TB control program has dropped. Okay? So way back to the time when I was still training with Dr. Razal. I was not even a chest consultant at that time. So that is what it has done after 1 year. And so WHO came up with a subsequent statement after that for the World TB Day, and they said almost the same thing, reduction of 21% of people receive their care for active TB, which will result in an additional 500,000 TB deaths. And we all know TB, when you're talking about 500,000 TB deaths, I think if you see the statement before I go back a few slides, we are not talking about 2021, 2022. So TB deaths will probably come 2024, 2025. It is a chronic disease. So by the time you pick up the bad disease, it will probably 2-3 years later, and then you start seeing the death rates later on. Right. So this is the case notification of 84 countries for your WHO. So all the notification were doing very well up to 2019, and come 2020, all dropped. This is globally 84 countries, and what is worrying is the top 4 countries: India, Indonesia, Philippines, and South Africa. So most of it dropped. Okay. So India was picking up towards the end of the year, but again, this is 2020. We don't know how the graph will look like in 2021. So if you want to look in the rest of all the countries, it's the same thing. So you look at all the graphs, is all like go up, come down, Bangladesh, everywhere. The only thing that did very well is DPR Korea. This is North Korea. So North Korea up to now, I think they got no COVID apparently. So when you got no COVID, then your TB control program probably comes better. Not sure. But if you look like Thailand, for example, in 2020, you can see the lines, the dotted line is what is expected. When WHO projected, this is how much you should, like for example, Indonesia, the dotted line is what you expected, but in 2021 it dropped. Thailand for 2020, they were actually doing quite well. So you can actually see when your health system is not so overwhelmed, you can actually maintain your TB control program. I mean, it's an indirect way of looking at it. Okay. So, and then they came up with the key outlines that we need to do, actions that all of us treating TB need to do. So there's a lot of guidelines. So this will probably take me to my second part of the talk. So I think now they have strong emphasis on treating LTBI for household contacts. I'm not sure whether you all know, in July 2020, there was actually a circular that came out for this for our ministry. So when you see your contacts nowadays, you should really screen them for LTBI and start to treat them. Because these are the patients that might likely get active TB 3 to 4 years down the line. They also came up with this. If I got time, I'll touch briefly on MDR TB, but if I run out of time, I will just stop at that point. So this from 9 April, the TB, this is the main meeting we go through every year. And I must admit, this year, 2021 was probably one of the most depressing ones that I've attended when you look at the figures coming out. So how did we do? Actually, not too bad. The blue rate is 2020. So our registered TB cases dropped a bit in the first MCO. But we picked up very fast, as compared to 2019. So we just followed up. So a bit of lag, but not too bad. I think Malaysia graph was not too bad. But the notification rate, as what dropped, also we dropped. So if you look at the rate here, is 7.2. 72 per 100,000. The common thing people think is, like everybody wear masks, everybody did social distancing in 2020. So of course the TB cases will drop. That is not the way it works for TB. That probably works for your H1N1 influenza. That's why you practically did not have any flu last year. But for TB, when there is a projection given every year, the same way that you can predict, when it drops, it means that we didn't pick up the cases. Okay, so it's a bit of a difference there. So if you look at what they said, if you look at the drop at 72, if you project it backwards, it's correct. Like it takes you to about 2010, 2011. So it's about 10 years behind. We've gone back to the rate that time when all the states drop, and worrying is the states that that have very high TB burden, especially Sabah, when they were hit very hard with the COVID at the end of last year. So case detection rate also dropped. Every state was below target, and nobody achieved the target last year. And I think but what is sad about Malaysia is when it comes to mortality, that's the only thing that went up. So even though we had less cases, our mortality rate went up. Highest in the last 20 years was last year. It's very sad. Many people still die of TB in Malaysia in 2020, at the time when our pandemic was not too bad at that time. Okay? So that is something we need to look into. So who are the patients who died in 2020? Most of them will die within the first 30 days. Half of the patients will die within the first 30 days of your diagnosis. So you need to keep in view of that. So this orange color box, 48% of that were among the elderly more than 60. But which means 52% who died were actually less than 50, less than 60 years old. So that is also something to be a bit worried. So you need to look into all the TB mortality. So when it comes to this SDG that we always been talking about since 2015, that from 2015 to 2020, we need to reduce the TB incidence rate by 9%. Malaysia reduced by 2.4%. TB deaths should come down by 35%. Ours went up by 36%. Very, very, I mean, if you don't achieve it, it shouldn't have gone up so high. Okay. Catastrophic costs, we are doing a study within this year, so we do not have prior to this, but we probably have data in the coming years. So that will probably bring you to now what can we do now is our LTBI program. So LTBI now has become quite a concrete program nowadays. So under your objective, your TB control program number 4 is actually on LTBI. So now it's a hot thing, LTBI among contacts. So this is the latest guideline. I think this is what Datuk presented last week. So this probably, I mean, it's almost the same as the 2015 guideline. Just they made it a bit more nicer. You can probably go and it is readily available in the WHO website. So you all can download it. So I won't go through in so detail. I think introduction, most of us know what is LTBI. 1/3 of the world population has LTBI, and it's the 5 to 10% lifetime risk. So it's very high that you will actually turn to active TB. And but treatment is quite efficacious. Treatment is actually quite good. The monoisonazide treatment or whatever treatment regime you use can actually treat LTBI quite well. So it's something worth treating. When you have an efficacy rate of 60 to 90%, it's something like the Pfizer vaccine. Okay, so for HIV, there's no questions asked. It's very strong recommendation. Anybody with HIV, even though your TST is unknown, once you rule out NTT, once you rule out TB, you should treat them for LTBI. Okay, the regime recommended is 36 months. I don't know whether our ID practice that 36 months, but that is what is recommended. I think many of us still use the 6 to 9 months treatment. But for this, the evidence is very strong. So for those of you who are sitting in the HIV clinic, probably need to consider this. Right, HIV negative contact. So these are what most of us see in the chest clinic. When they do the contact tracing, the patient would be a smear positive patient. All their contacts, what you do. Okay, so for this year, 2020, what they did was they divided it. So for children, again, no questions asked. Children below 5 years old, you treat. So in countries with low TB incidence, then the evidence is strong to treat. Okay, so we are not there. We are intermediate, high. We're not high, we're intermediate. Okay, there's no countries for intermediate, but for countries with high TB incidence, what they say is here. So you actually need to treat based on your availability and capability to treat, because what they're trying to say is if your incidence is high, you concentrate more on the active TB, okay, right? But if you have the ability, then please go ahead and treat. And I think Malaysia, we have the ability and capability to treat. Okay, so this probably does not, this caveat probably does not apply to us as much as other countries. So we are quite fortunate in that sense. And again, they have all the other HIV negative groups that you should consider treating. So again, the biologics, I think this one is a no-brainer for all those rheumatology patients receiving dialysis, so on and so forth. Okay, and then the low incidence for healthcare worker is the same as how it was in 2015. So we healthcare workers, we are in the same group as the prisoners, the immigrants, homeless people. We are all the same friends with them. All the IVDUs. Okay, so whether to treat or not, that is what it is systematic treatment testing and may be considered. So we are under the may be considered part. Not recommended is patients with diabetes, so on and so forth. So but this one, I think we have a big problem with diabetes in our TB patients. So I don't know whether this actually applies to all countries in the world or not. But they say because based on what their evidence is, and I think these papers are probably done in countries where their diabetic rates are not so high. Diabetics apparently with LTBI do not proceed to get active TB as much as the other groups. But I think we need to fine tune it. I mean, if you have a diabetic patient who is a contact, then definitely you need to treat. Right, so the algorithms are all there for you all to go through. I think I saw a few of my trainees in the talk, I think Faisal, so on and so forth, in participants. So you can probably just, they might ask you this in your exit viva. So if you look at HIV with TB, you will notice in the algorithm, there's no mention of igra or TST. You don't need to do that. So if you have a patient now coming with HIV, you just screen them with the symptoms. If they've got no symptoms, no contraindications, straight away you treat. Okay. The minute they got symptoms, then you work out for TB or any other opportunistic infection that they might have. So it's very straightforward. Okay. So if you just follow this no, and it's give preventive treatment, right? Same thing with the children below 5. Children, so that because in children, the algorithm also very easy to see. Okay. Not so complicated one. Any children who is a household contact, if they are well treated, okay, then need you evaluate for TB. So they've made the algorithms very simple. Again, you will notice there is no TST. Don't go and do mental test for children below 5 years old. Very traumatic for them. They never come to the hospital after that. Right. The only part when you see TST or igra is here. So these are the main group that we are targeting now. Okay. So if you notice how we used to work last time was all our contacts will have chest X-ray and MN2. Right. So it's already done for us in Malaysia. So if they've got no symptoms, you do a igra. If igra is negative, well and good, you can actually discharge the patient. If they are positive and chest X-ray is normal, then you treat for LTBI. Okay, so that is what we are now trying to. I mean, for those of you who are sitting in TB clinic, I know many of you are already pulled to either study or COVID. But whenever you do the contact tracing, I think you need to bear in mind this one. You need to actually start to counsel your patients for LTBI treatment. We are talking about contacts, right? So testing, a big question everybody likes to ask is which one is better? You want to do your igra or your TST? So this is WHO guideline. So WHO guideline, they make it for the whole world. So for the poor and the rich countries. So they are very clear. They said either one. They don't put one over the other. It's either one can be used to diagnose your LTBI, right? They do say some benefits of one over the other. So this I think is reading. You can go back and read. So, so for example, TST may require fewer resources. So if you look at WHO guideline, whether it's their TB guideline, their LTBI guideline, they are made to look, they focus a lot on resources because we take our resources for granted in Malaysia. We have things very simple, but you look at what they say sometimes. For example, igra, what are the problems? Igra, they say requires blood taking, which can be difficult. Okay, laboratory infrastructure, which may not be there. Technical expertise. So these are for maybe the poorer countries. Okay? So for them, maybe igra is not so much of an option. TST is less costly. So you see that they always mention things about resources and costs. Can be performed in the field. So Malaysia, we don't go to any field. We have no field to go to. We are all very urbanized. Even our rural areas have very good health system. Okay, right? So field means is the one that when you go into the desert or the jungles and all that, right? Requires a cold chain. So in that cases, maybe TST is going to be difficult. So that at the end of the day, they say both almost the same. So you see what you have access to, and you just use whatever test you have. Right. Treatment is the same as the 2015 guideline. It hasn't changed that much. So it's very wordy. So basically, these are the regimes you have. I think the 6 months isoniazid monotherapy is still the one most of us are familiar with. The study that was done was with the 3-month rifampicin. This one, there are a lot of papers that say this is probably, if you're going to ask me which is the best regime, then probably this is probably the best regime, the weekly rifampicin isoniazid regime, because it's easier to take. It's just once a week, and it's much shorter, half the duration. Okay. Of course, all treatment is given by your weight. Right, so this is back to our slide. I'm sorry, when you see these slides, I must thank Dr. Asma from Sector TB in KKM. She provided me with all these slides. Very kind of her. So all the figures that you saw was all prepared by Unit TB, and the slides came from Dr. Asma. Right, so the target now for KKM now, you see number 3 is contact of TB positive you need to treat. Right, so contact among cluster also you need to consider. Right. So the concept is basically like this. If we do what we are doing all these years, you just treat active TB, you will never reach this dotted line of this 90% reduction of TB. Because what you're doing is you're treating them as they come active, but their big reservoir of TB, their latent TB remains untreated. So you treat that, then eventually the latent TB will come TB. You're not plugging the hole in the boat, so to say. So for that, you need to treat latent TB. So when you treat latent TB aggressively, then you need a blue line, you'll probably reach your target by 2050, right? So I don't know now with everything is pushed back, it's probably higher than 2050. So now that we have all this in our guidelines, how are we doing? Actually, surprisingly, among our pediatric, I don't know whether any pediatricians now, only 18% actually give IPT for those age less than 5. I'm not too sure why this happens. So these are the contacts that they know, and these are the people who actually get IPT, quite low. Different states have different varying. Right. Similarly, among patients living with HIV, there's been a drastic drop. I'm not sure why. Suddenly, there's not much pickup among patients going straight. I think it's one of the feedback I get is there probably a lot of pill burden already. So probably they do not want to add in another treatment, or probably the drug interactions. We're not too sure. Again, it differs from state to state. Penang and Johor, almost 90% of the HIV treatments, HIV patients get isoniazid monotherapy. Whereas the other states it varies. Okay, between 2019 and 2020. I think importance I already stressed because if you just keep treating the active TB, it's going to be quite difficult to eliminate TB now. So we need to start changing our focus to treating LTBI now. So what we did, this was done 2018. I think Dr. Laita was involved. This was the pilot project where we used igra and then we treated them. So 24% was the positive rate based on igra, not MEN2. So when you tested, it's about 20 to 30% normally you will find LTBI in your population, right? So what did we do? We actually treated them. No need to look at all the numbers, but because it's a study, this is a study. So study normally they tend to complete their treatment because they are always called and reminded to come for their appointments, so on and so forth. So 80%, 82% completed LTBI treatment, which is very good, very good, quite high actually. 32% refused because this was a study. If you look at those who developed TB within the study period of 2 years, total 4.9 of those that were not on treatment developed TB. The whole group, 1.8% developed TB, but a large proportion of those who are not on LTBI treatment. So that means, remember I said 5 to 10% will develop TB in the early, especially the first 2 years. So this is local data that actually shows that it's true. So sometimes when you see patients, especially when the contact is a very bad smear positive TB, I think you need to make them realize that it is 5 to 10% that you will develop TB. So you might, it is worried to take the LTBI treatment. So this is our local data. So then we came up with this paper in July 2020, which kemas kini makluman pelaksanaan ujian saringan TB kaedah igra. So now igra is readily available wherever you all are. So it is now recommended for beginning July 2020. Those who are if your contacts are smear positive, you can actually send them for igra. Okay. If you have a cluster of TB, now cluster, everybody talks about COVID. I don't think we have any cluster TB going on now for the last 1 or 2 years. And a healthcare worker. So your healthcare workers, so you can consider them to do igra, and it's now made readily available. So these are all the states, the MKA labs. So which state, for example, Penang, we send to MKA Ipoh, there's 3 incubators there. So there's incubators all over the country, wherever you all are, for you to send your igra to the nearest MKA lab available to you. So they have bought about 50 incubators just for igra. So you can ask the TB control program in your respective states now. So this is what we had in 2020. So these were the samples that were given to each state. So they were given a certain number. I think 2020 not made again as we were more into COVID, so the pickup was not too great. Like for example, Sabah, you can't blame them. Only 7.9% was done because Sabah was hit quite bad by the COVID. So overall, 30% of the patients were tested, and again you will see about 20% positive among the contacts, right? Intermediate, nowadays intermediate rate is coming less. For igra, you have intermediate. Intermediate normally we recommend to repeat, but I think the rate has come down now as the testing improves. Right. So who goes on treatment, and then there you see still some of them refuse, 10% refuse, but actually some do quite well. 70% of the patients were actually, when you counsel them well, they actually go for treatment. So we have started to pick up to 100% to treat all contacts. Okay. So do I still have time? So very fast. MDR, I don't have that many slides. So that was my LTBI. MDR is a national emergency. These are our MDR cases. So now, because of Gene Expert, we have also rifamycin resistance. So we have RR and MDR. Okay, so not too bad. The blue bars. We also have XDR TB in our country nowadays. We have 3 cases. I think this year about 1 more. So success rate is not too bad. Mortality rate is about, most places will quote 20 to 30% mortality rate for MDR TB. It's much higher than normal TB. So our success rate was about 70% with the cohort of 2018, because MDR is 2 years. So we don't have the cohort of 2019 yet. It's 2 years treatment. So MDR, if you look at the drugs they recommend nowadays, just for your interest, we divide it to group A, B, and C. So Malaysia, we've been doing things the other way around. We've been using mostly group C. So the aim is you use as many group A, group B, then you top it up with group C. So group C agents are added to complete your regime. So it's very flexible, but try to get all the A and B. The problem with A and B is bedaquiline and linezolid is extremely expensive. But for those of us who have used it, when you put these drugs into the regime, it becomes much simpler. You do not need to have an injectable. So gone are the days of injectable for MDR, especially now with COVID. You don't want patients to come to the hospital for daily for the injection. So we are trying to opt for a full oral regime. So this is the working paper we put in. So if you're going to convert to oral, that is the cost for 200 patients. Actually, compared to what other biologics, so on and so forth, is not too bad. 9 million to treat 200 patients. And you will notice the bedaquiline, for those of us who have been involved in bedaquiline, when it first came out, it was 80,000 for one patient, but they dropped the price. Similarly, linezolid was 80 ringgit per tablet. Now the price has dropped. So it's come cheaper now to treat MDR using the new regime. So you can opt for the clofazimine, or you can opt for the cycloserine, either one. So the price will just change. The clofazimine regime will be cheaper. So this has been put up. So hopefully, I don't think we're going to get anything this year. This is all the work thanks to Dr. Zamzurina from IPR. So she has been pushing quite hard to get the easier regime to treat our MDR patients. So I think we have a lot of challenges coming in, but I think the main reason for the talk is the last one. There is low intake of TB preventive treatment. So I hope that this talk will increase your awareness and to how to diagnose and really consider treating LTBI. Because when the COVID goes off, if you look at what is going to happen by the rates that we are picking up in the last 1 year, 2 years, we expect the rates to increase tremendously 5 years down the line. So it's better to catch them early before they develop active TB. With that, I would like to thank you for your attention.
Thank you, Dr. for a nice lecture and also very informative kind of talk. We got a few questions on the line. The first question actually is in the chat box by Dr. Y.C. Lu. Would the universal masking reduce the incidence of TB transmission and therefore new cases in the long run? Also, the use of masking, would that decrease TB?
Again, I thought I didn't get that. Sorry.
Using mask.
Mask.
Would that decrease the TB? Yes, correct.
Oh, mask. I think that for TB, the best mask is N95 because it's airborne. It is N95. Actually, now COVID also they say it's airborne. So sometimes the surgical mask. That's why CDC recommends double mask. Yeah, I mean, it probably would help to a certain degree, the droplet part of it. But the actual spread, because it's airborne, it can actually, if you want best protection, is N95. But I mean, any mask would do. Like N95 is quite costly, so probably it might help. Normally, what we think is you mask the patient and you mask yourself, then probably there is some degree of protection.
Another question about the same Dr. Y.C. Lu. Are all the states and cities different in TB burden and therefore requiring different treatment strategy with respect to LTBI?
No. Because I think LTBI, the way we treat is the same. That's why the guideline gives you maybe the way you're going to diagnose if you have igra or you have TST. That's why the guideline says either one. So it depends on what you have. The main aim is you need to pick it up. Okay, so if you suspect the context, if what Malay the KKM now has now is they put igra in multiple settings. So if you have contact, you can actually ask for igra. So that will probably help you. So it doesn't, the treatment strategy in treating and diagnosis remains the same. Yeah, you just need to pick it up and then you treat. So the treatment that we use is also the same. So our private
I think the question is different states got different TB burden, and did it require the same strategy for LTBI?
Yeah, it doesn't really depend much on the burden. Like the higher the burden, you have to put more. The strategy remains the same. Probably if your burden of activity is so high and you cannot manage it, sometimes the common feedback we get is there's so much resources gone to active TB, you do not have latent TB. Yeah, so probably I think if that is the source, you still need to try to improve, to try to pick it up anyway. So that's what the ministry is recommending nowadays.
The other thing about the igra test in the government, can the private patients go and get it done in the government?
Once they register, once they register in under us, I think can, but they cannot just simply go and do it. So basically, what happens if the private they are diagnosed, then their contact tracing normally at the end of the day they actually refer to the government anyway. So maybe your index case might not be under you, but if the contacts come to you, then probably yes, you can do it. Because this is for contacts.
Yeah, sure. Okay. There are some more questions, Dr. Irfan. This is from the Q&A box. If the TST is positive but igra is negative, would you consider it as latent TB?
Yes, either one positive should be considered as far as I know. So sometimes there are some the way the test is done or what your igra might not be positive or so on and so forth. So and there's no role to recommend tool. I think the older guidelines, yes, if your TST is negative, then you do your igra. Or if your TST is positive, you want to confirm, you do a igra. But nowadays, if you have one, then probably that's good enough. Having said that, because igra is so sensitive, if your igra is negative, a bit hard to diagnose LTBI as well. So sure. Probably, yeah. So the previous way they used to think about it was igra was more sensitive than for your MEN2, your TST. So let's say if you strongly suspect and your TST is negative, then probably you can, if your TST is positive, it might have picked up some other, for example, NTM, so on and so forth. Or maybe the patient scratched it or something. So in that case, you want to do a igra, and your igra is negative, then probably it's not LTBI. So I think it needs to look at the overall condition. So why was the igra recommended? So if the TST was done and for some reason you think that it might not be reflective of that particular patient, you do igra, then yes, maybe you can follow the igra.
Sure. There is one, Dr. Eugene Tan. If someone started on TB treatment for smear negative, and if I do will it be positive? So the patient
chances
started
are
TB treatment with the smear negative.
Yes. Chances are be positive because igra just detects your the TB within your body, whether it's active or negative. But if the TB is, if you're already treating somebody for active TB, if you started somebody for TB treatment, even if you're smear negative, you probably have X-ray changes or they have symptoms. So when you have these two cases, you do not think of latent TB. You tend to err on treating the active TB. So there will not, your igra might be, most likely will be positive, but it doesn't matter about whether you're going to treat LTBI or not, because you're going to treat active TB. So your isoniazid is going to be there anyway.
There's one more question here on LTBI. Would you consider LTBI treatment for patients that do not have any TB contacts? igra done for medical checkup.
Yes. Okay, for this one, you need to talk to the patient in detail. For our guideline recommends for those who have got contacts. So if a patient goes for a checkup and comes back igra, actually by right, you can offer them the treatment. If the patient is going to comply to treatment, then probably, yes, you can treat. There's no harm treating them because your treatment is quite efficacious and it's relatively safe. Okay? But we would not do, what I mean is we would not do igra as part of the regular medical checkup for all our patients. We are now, if you have to choose, you choose the one that contacts to a smear positive. The reason being is because you have, in a way, you've broken the chain of transmission. You're already treating the active index case in the house. And you've already treated all the contacts there for LTBI. So there's no more transmission within that house or that household, so to speak. Whereas when you have any other patient out there, igra done in medical checkup, that concept of creating that treatment within the household doesn't come in. But to answer the question, yeah, you can consider treatment. No harm.
Yeah, I think they should treat, because when the igra is positive, they can get TB from anywhere in the community.
Yes. Yes, I think so. I agree that we should treat.
Yes, right. Thank you for your lecture, Dr. Irfan. The question here is that what is your suggestion to monitor?
Right. So
LTBI patients if they refuse treatment?
yeah. So I think the monitoring is still the same now. We still recommend that follow up for over 2 years because that's the time when they may develop NTB. But normally what we tell all our contacts, in fact, what we tell our patients after you've completed the 6 months of anti-TB treatment, you should always warn them of the signs of TB, of active TB. And we should educate them again. So if you don't want to take treatment, fine. But if you start having the symptoms, don't go and cough for 4 or 5 months, then you go and seek treatment. Because we already know you have TB inside you. So if you're going to go for 2-3 weeks, quickly go and get an X-ray check sputum, then we will probably treat you for active TB. So that is probably the best suggestion. Having said that, I think we should try to convince them as much as possible to take the treatment.
Yeah, so I think it's very important. Yeah, especially if they got risk factors to get TB. Yeah? If they got some immunocompromised state, they are diabetic or immunocompromised and taking some steroids. I think it's very important. Yeah, how frequent should healthcare workers be tested for latent TB?
I think the current guideline is 2 years when you first start working, 2 years and when you're about to retire, I think. So that is the time when you treat, when you test for latent TB. Okay,
so 2 years once.
Yeah.
So what is the turnaround time for igra from MKAK?
Okay, what I was told, it used to be quite fast, but the last, we just sent for some of our staff nurses, we say it took about 2 to 3 weeks to come back. So I think, I'm not sure why, it's about 2, depending on which MKAK you send. I think within 2 weeks, you should get it back. You should get it back.
I think it all depends on the load, isn't it?
Yes,
yes. Because they do by batches. They do by batches. So they now depend on the load. Yeah. If they got very few cases in their center, then they wait for the patient load to be there, then you do one shot.
Yes, correct.
So if you got a big center with a lot of TB patient for LTBI, then they can actually turn on time faster.
Yes. So it depends on
there's one case for close contacts who have completed IPT. Should they get exposed again in the future, can we repeat the again? Thank you.
Yeah, this is the tricky part. I think Dr. Thomas. So there are papers that say that even after you've completed your 6 to 9 months of your isoniazid monotherapy, your igra may still be positive. So there's no role to repeat either your MEN2 or your igra after treatment. That means you take 6 months. The studies have shown that works again. So you don't need to repeat. So in the future, should they get exposed again? I don't think there are any studies to this, but I most of the time you only treat once. You only treat once.
Correct. I think WHO also says only once only.
Yeah, you only treat
once.
You treat
them only once, and then the main thing is that you have to make sure that the place of work actually is a safe place to work.
Yes.
That's why you must make sure the Pangara and all the healthcare workers are all actually doing the PPE properly. Make sure there's good ventilation and everything to be done. That's right. Yeah, so we give them only once only.
Yeah, I think that's very important because what they're trying to say is we want to knock off that 5 to 10. So if you look at a graph of a person's life, let's say you're age 30 and you're LTBI at that time. Now you're 5 to 10% chance of getting it in a lifetime. So when you knock it off and it goes back to 0 at age 30, then you probably will not rise up again in the future. I don't know if that makes sense what I'm saying. But it's definitely you treat once and then at the end of treatment, you just tell them that warn them again of the signs of active TB should they recur.
Sure. I think the last question, I think, is the same thing. How many rounds of LTBI treatment can be given to healthcare workers that have a repeated exposure to TB patients?
Once in a night.
People are given eye. We see patients every day.
Yeah.
So we do only once, yes, correct. Same question. We do only once. Okay, correct. Do you recommend TB prophylaxis for HIV patients, even though the viral load are very well controlled?
Yes. Actually, that was, if you read the guideline, it's stated there. They recommend for all HIV patients, regardless whether they're on heart, regardless of their viral load. So that is strong. It is recommended to treat everyone, regardless of their igra, whether they're on heart, their viral load. You just treat them.
They don't have to do chest X-ray.
Yes.
Go by symptom only.
Yes.
And they don't worry about viral.
Active, yes. All
HIV positive patients, they should put them on LTBI.
Yes.
Possible.
Yes.
I think, Dr. Irfan, you answered all the questions very well. I think there's no more questions, unless there are any other questions coming in soon. Dr. Ang, any other question coming?
No more questions as of right now. So I think we can end the session. Wait, there's one now.
Yeah, if the healthcare worker are well aware of the TB symptoms, would they need LTBI treatment?
If they have, if you confirm with LTBI, yes. If you have the treatment with LTBI, yes, you have to treat them anyway. Because I mean, what I guess the question is trying to say, if we are very well, then when we get symptoms very early, we quickly go and treat active TB when it comes. But that is not the way to do it. Like, you want to knock off the chance of getting active TB anyway, whatever way. So if you have any healthcare workers who are positive, you should treat.
Yeah, I think it's very important. I think they got you don't wait for the symptoms to come.
Yes, sir.
If it's very positive, I think we should convince them if they got high risk to get TB in the future. Okay, there's one question here again. Any other option of if patient can't tolerate isoniazid or rifampicin? Any other drugs can be given to the patient?
No, I think most of the regimes have one of these drugs as their backbone. I'm sure if we look, there will probably be some. But I can't. Most of the regime have either isoniazid or rifampicin on board. I don't think they will use without these two drugs. So I'm not aware of it. So maybe in these type of patients, because one of the caveat is patients can actually tolerate LTBI treatment.
Yeah, sure.
So if they really cannot, and you've tried, then probably.
I think Dr. Irfan, I think you're correct, because the moment the patient has side effects of any of these treatment, I think we should not push them.
Yes.
Because this is just a prophylaxis treatment. We don't want to put them in trouble.
Yeah.
If the patient got all these allergic things, like what they call all these complications, we just tell the patient to stop treatment and then monitor symptoms in the future and see whether they get any symptom of TB coming or not.
Yeah. Agreed, Dato. Agreed.
Yeah, sure.
We don't need to go and do drug challenging and all that for LTBI.
Yeah, we don't do that because this is only prophylaxis. Good, Dr. Irfan. I think we answered all the questions very well. And there's one.
Yeah, Dato. Is the line okay?
I think Dato's line is unstable.
Yeah, line's okay. Yeah. Okay, sorry, mine was stable. Okay, good. So if the patient default treatment after IPT for 3 months, would you restart?
I mean, it depends why he defaulted, but normally we don't restart. It's not like active TB where you have to really, and they give you a period to take your treatment. So it depends how. If they defaulted very long, then probably no need to restart.
Yeah. I think the main thing is that if they default treatment, we do not start them again.
Sorry, Dato?
If the patient default treatment, we don't start again.
Yeah, we don't start again. Yeah.
Yeah. Because maybe in the future, definitely get TB, then you worry about the INH resistance.
Yes, yes.
Yeah.
There are studies that show that you're using 1 or 2 drugs does not, if they do develop TB, active TB later on, they will not get resistant to those drugs. So I think that's another thing many people are worried about. So that doesn't really occur. So if this patient has already defaulted, then probably you just stop it and hopefully he's been treated with that, whatever you've given him, and look out for the active TB.
Another nice question they're asking there, if the contact is more than 3 months ago, would you offer LTBI? Yeah,
so if the contact, I mean, we have treated patients where the contact may have been many years ago. So the minute you diagnose LTBI, even if the contact has been quite some time ago, it's still considered a contact. You should still consider treatment. Basically, what we're trying to say is, if you pick up LTBI and the patient in front of you is a good patient who's going to comply to treatment and not going to develop any side effect, I think because later on, they may get diabetic on the elder age and so on and so forth, then they get active TB. That is what we're trying to prevent in the years to come. So I think we can still treat.
Yeah, in fact, for contact, for the contact, the first 2 years is very important.
Yeah, correct. Datuk's line keep getting cut, Datuk.
That's where they get the highest chance to get TB.
Yes.
Good. Dr. Ang,
I think all the questions have been answered. We have completed all the questions. So I think we'll end the session today.
Yeah.
Later on, we'll put up the QR code on the screen. So you all just need to scan the QR code for the CPD point. And for the advertisement on next month, our weekly webinar will be focusing on neurology. So please attend the neurology session for next month. Later on we'll put up our posters on the Facebook webpage so that you all can register it online.
Yeah.
Thank you for the session.
Thank you, Dr. Irfan, for a nice lecture, and also Dr. Ang for sharing this thing. I'd like to thank the College of Physicians for inviting us to give this talk again. Thank you very much to all of you and the participants. Thank you very much.
Thank you. Thank you.
Thank you, Bajwa.